Hello, Assalamu alaikum. Hope everybody's fine. And today we are here with our free webinar, which I will be explaining regarding how the gynae's exam is going to be modified, especially in terms of talking to FCPS. So how many of you have already attended my session? Is there any new person who's been here with us? Hello?
Doctor, I have attended last session.
Okay. So I will be actually telling all about again regarding how the exam is going to be conducted, the new terms and conditions, and the way you have to go through this exam. After this, we will be discussing one case scenario, and I will be needing a volunteer for that. How that question and exam would be coming and how we have to take it forward. So regarding this, first, we will be telling you everything so that you can do it in your first attempt and you won't have any problems in achieving your goals. So regarding the program of the work, so it would be like, first we have to, I will be telling you all about regarding pattern of extended OSCE examination, the total number of stations, and the time distribution which has been given, and divisions of modules. The detailed breakup of each station in different domains with static and interactive stations and examination stations with structured discussion and props with boards. So regarding the pattern of extended OSCE total station in exam, these are the number of stations would be 12. So it depends upon, so actually they're trying to mimic this exam or translate this exam into a new format, which is actually going on in different international exam pattern. So, it would be a similar type of exam, the way you have all gone through your IMM examination. But the difference would be there, in your IMM examination, you used to have only 6 minutes or 7 minutes, but right now you all will be having 12 minutes for all of your stations, where 2 minutes would be stations where you will be given a question to think about what that question is, and in that question, when the question will be shown to you, there will be a paper and pencil, and you have to write down that question, the important points which you see in that question. I would all encourage you to write down this pattern, so that once we will be practicing this session with you, you will come to know that how you have to do it. Still, I have placed one station to practice, so that you will all know that actually how you will be giving your exam. So reading time would be 2 minutes and performance time would be 10 minutes. In 10 minutes, you will be given a role player station in which you will be talking to your role player. That will be in your Urdu language. So in that 2-minute time, you need to make the whole agenda, which you'll have to talk to your patient in 10-minute time, and examiner will be observing you throughout that time period. Similarly, this will be a role player station, so that will be also, that might also be a structured discussion station. That means structured discussion is called as a short viva discussion. So scenario will be given to you, and you have to take 2 minutes to read it and just try to format your mind in 2 minutes, how you have to avail those agenda while you're talking to your examiner, and how this 10-minute station would be broken off. I'm going to discuss about that domains also. So that you will be able to have an idea that keeping those domains in your mind, you can talk to the examiner and present that topic which has been given to you to the examiner, so that you won't get failed. So the next thing is that of the division of modules. So how the 12 stations which you will be presented to the exam is divided into different cores. So there are actually 12 stations. So they have divided them in according to their 12 modules. So there may be a one station which would be on gynae and sexual health. So in gynae and sexual health, you might come across a patient or a structured discussion that would be like endometriosis, or there will be a question like gonorrhea or sexually transmitted infection, or there may be a postmortem problem. The postpartum problems would be like the patient may present with you endometritis or secondary PPH, or there will be a discussion or a guideline discussion of a patient presented to you with third or fourth degree tear. Similarly, there will be two more stations that will be on the topics like management of labor and birth. So labor and birth, like they can be emergencies that can be given to you, the pre-eclampsia or shoulder dystocia, or there may be some other discussions like they will be given us, and they may give you a scenario of eclampsia and they want you to discuss that with the examiner. Similarly, they can also place problem like caput secundum, which has taken place after vacuum birth, and now the mother is talking to you, or the examiner wants you to discuss about dealing with such kind of emergencies. So they're actually as trying to assess the management of labor, that how you being a doctor are going to manage it. Similarly, in that station, they can even put across a labor board. The labor board will be, which you have already given, would have an idea while you have given your IMM exam. So there may be 7 or 8 rooms. So in case of the part 2 long case or extended OSCE pattern, so they might make a little bit difficult for you by involving more number of the rooms, and 3 or 4 would be of major emergencies. They actually want to see that how you would be treating them and prioritizing them. Similarly, early pregnancy usually has 3 or 4 topics. So there may be a one station that would be encompassing your topics like molar pregnancy, that might come as a structured discussion, or that might come as, talking to the examiner, or also talking to the patient at the same time. Similarly, recurrent miscarriages is a topic which comes in early miscarriage pregnancy, and also ectopic pregnancy, and the miscarriages. The other top stations divided into oncology and antenatal care. So oncology, there will be a breaking bad news. The patient would be sitting in front of you waiting for the reports to be discussed, or the examiner would like you to discuss about cervical cancer. Okay. Similarly, antenatal care. So there will be problems like female genital mutilation or domestic violence, or there will be a topic like obesity in pregnancy. So these are the topics that usually comes in antenatal care. That may be in the form of rote layer, like vaginal birth after cesarean section. She had a cesarean section 2 years ago, and because of some reasons, because of breech delivery, and now she's here to talk about the next delivery plan. So this is how they have divided the stations. Next to station, you might see a station on instrument. This is similar to the one you have done in your IMM examination, but there will be, because that is actually going to be a greater 10-minute station. So they might ask you to perform it and to do some more structured discussion over it related to the instruments. So the instruments might involve your instruments like forceps, low cavity, mid cavity, or ventouse cups, or they can also use a simple instrument which you have never ever thought before, like speculum. And so you need to prepare, smallest of the instruments also for your vivas, and also the biggest one like laparoscope and hysteroscope and the cystoscope, which we have never usually, we usually never come across these kinds of instruments because this is not our specialty. But now you're appearing to the FCPS, so you might expect this kind. You might expect even TVT or TOT. So you need to explain, please explain this instrument, how you're going to do this, what is the indication, and blah, blah, blah. So regarding the maternal medicine is one of the, most important station, not only for the international exam, but now they are also going to make this in your exam also in the long case. Actually, most of the cases were in the OBS when the pattern was different. They used to discuss about preeclampsia or GTM. So now here, they will be discussing you in the form of a 10-minute viva by giving you a scenario, or by giving you a role player in which you will have to take a 4 or 3-minute history and talk to the patient regarding how she will be managed. Similarly, there will be a station regarding urogyne. So urogyne have pet topics, and if you prepare this urogyne, 3-4 topics, then it's really sure for you to go through the station, and it only involves for just pelvic prolapse and the stations like overactive bladder or stress urinary incontinence or recurrent prolapse or POPQ. So these are the things, if you know it by heart, so this is, yeah, it's a very easy station to go through it, because there is a PET template you have to ask to the patient, and you have to talk to the examiner. Examiner is also not urologist, and you're also not a urologist. So it's a really lovely station. So we will be discussing it throughout our sessions, and you would love to do it with me. The next session you might expect on reproductive medicine. So this reproductive medicine involves the topics like um, subfertility, that will be primary or secondary, unexplained, or endometriosis, or tubal factors, or you may expect topics like OHSS, polycystic ovarian syndrome. In terms of, polycystic ovarian syndrome can also come in gynae station, and it may also come in reproductive medicines, because if she's unable to conceive, so how you have to take it along. Then eventually IVF, the protocols of IVF, the guidelines. You need to see all these topics in this kind of a station. The next one is core surgical skills procedure. So this is also a lovely station, and the easiest station to pass through, because it may involve the talking to the examiner, things like um, abdominal hysterectomy procedure, which they used to ask you when you had a long case in gynae. For example, you're talking about fibroid and heavy menstrual bleeding, and end up by telling the examiner about how abdominal hysterectomy is done. Similarly, now they will be dividing into core surgical skill station, where they might give you a scenario, or they might be putting you in a position that you're in operation theater, standing with your supervisor, and now your supervisor actually wants to talk to you about the steps of the abdominal hysterectomy or vaginal hysterectomy or ectopic pregnancy or laparoscopic procedure, or there might be some complications that have occurred, for example, ureteric injury. Now, how you're gonna investigate it, and how you have to talk to the examiner about managing it. And uterine injury is one of the most hot favorite topic, not only in Pakistan exam, but also for the international exam. So you should, learn this. They expect you to recognize this complication at once, and just, um, uh, manage it in collaboration with the specialty. Similarly, you might come across with bowel injury, you might come across with paralytic ileus in the station. So they might have given you different scenarios. They want you to identify this, and it's, dividing into different modules. They want to assess you in small parts, that are you a good doctor in postpartum problems? Are you also able to deal with early pregnancy things and oncology or instruments and maternal medicine? So like older type of exam, they used to have for long cases where there two long cases were given, and there were, you're only talking about two cases of somebody has having rare case and somebody's having more frequent case. So now here, everybody is going to have all the cases to be discussed in, equal manner. So the last topic is the one where you have to put, a lot of efforts, because this is a obstetrician and gynecologist as a researcher. Here, they want you to know about audits. They want you to know about risk management. They want you to know about different, um, uh, critical analysis or appraisal of different papers scientifically. So you need to know all these things, and there would be a one station, because now research has been very important part. So this is actually regarding the research about, you should know about the clinical governance. So the clinical governance is a part of, research type of a station, where it actually tells us that how our system is accountable by introducing audits, effective clinical effectiveness, what kind of research and development is going on, how we are open to our, colleagues, and the risk management, like uterine injury if it has occurred, how we can do different things to reduce it. And then education training of the doctors, which has been involved in whole of the, hospital environment. So regarding this, these are the instruments you might come across in the table that will be placed to you, and you might have to talk to the examiner, write this, right in front of him. Sometimes there may be a pessary, and there will be some gloves given to you. So just, have some, sterilization measures to be done. So they want you to have this. So these small things carry marks. So now how the breakup of a station into different domains would come. So if there is a structured discussion, for example, in the past they used to have diabetes. You went to the patient, you took some history, and now you came to know that it's a case of GDM or with recurrent miscarriages. Now you took the history, you went to the examiner. Now the examiner, you asked for the investigation, the examiner gave you investigation, the time got up. Now you summarize your case, and then you discuss with the two examiner 11 minutes with both of the examiners. So now they might split this whole station into two link stations. So you will be given in one station the scenario, and you have to discuss with the examiner regarding that investigation. So what are the important investigations going to discuss regarding this to the examiner, and why these investigations are important. So what are the initial management going to do? So the next station would also be linked, where you would be talking to the other examiner regarding the station, and they will be talking to you regarding how you're going to manage this patient. You have to do it on 10 minutes. So this maybe whole station would be in 10 minutes. So this is how they can also present you the case. So there will be after summary. There will be 6 or 7 obstetric cases and 6 or 7 gynae cases you will be having across in terms of division into different instruments or gynae cases, or oncology or antenatal care, or if we talk about maternal medicine. Regarding with the breakup of the station in different domains, if you're talking about a GDM of a pregnant woman who's presented to you as a case discussion with the examiner, so there will be the different domains on which you have to talk about. And these domains are, first you have to tell what information gathering has to be given from the patient, then talk to the examiner about what are the management options you're going to do. And while you're talking to the examiner regarding this, just keep in mind these 4 points: communication with colleagues, like multidisciplinary team involvement, communication with patients. For example, you have to, if this is you have to talk to the patient in lay language, so that not to confuse the patient, and give the correct information according to the evidence base. And communication with family members, that if the patient is coming with placenta previa and accreta, you have to involve the family members along with that she needs to be admitted at 34 to 36 weeks. And we need important role of the family, and also close collaboration to stay in the hospital. If she has kids, she must have family members to look after that. So these are small things, but these carry marks, and these stations have been divided into these domains. This is something you have to take care of in each station. Regarding the patient safety is one of the most important things. Patient safety is actually explained by your applied knowledge regarding the station. In placenta previa, you know about involvement of multidisciplinary team. So this is a multidisciplinary team is applied knowledge, that is your knowledge about the station. And this is also patient safety, because if you do not involve anesthetists, if you do not arrange the ICU domain or the ICU department, you're missing patient safety here. Okay, so if you do not do this, you're failed. Similarly, placenta previa patients, you need to arrange for the blood. This is your applied knowledge also, but this is also a patient safety, because now here, if you do not do this, your patients can bleed and may die. So if you do not speak up this, you're failing this station. Okay, so patient safety is something which is very important for that station. And you should think while talking to the examiner that you're not missing anything regarding that station, that if you miss that station, the patient may die. Okay, so this is something which is relevant to patient safety, and that makes you safer for you to pass through the exam. Okay, please guys do ask me questions so that I will be able to know that you are present and actively listening to me. And if I'm not making any point or any sense, you can stop me and can ask me at the same time. Okay, do you have any questions? Anybody has any questions right now, till now?
Madam, I want to ask, do we have to examine the patient? Will there any patient and on which we have to perform any examination?
Yeah, so that's a very good question. Yeah, so there will be in this kind of exam, you've got, one of the best thing is that now you're not interacting with the real patients. Now you just have to blurt out the examiner if there is no role player or if there is no dummy place. that you need to do examination on the patient because you want these things. For example, if the fibroid discussion has been going on, just tell important points of examination you want to do on that, like abdominal examination, and do the bimanual examination to see the size of the fibroid, to check the consistency, and things like that. Okay. Similarly, if there will be a mannequin, there might be a mannequin placed separately. So they might ask you to do the speculum examination, or they might ask you, they may give you a scenario outside. For example, the patient with DVT in pregnancy, and they would ask you to do 4 Leopold maneuvers. And please tell regarding how you're going to check the fetal heart rate. And then they can also ask about the examination of DVT in both legs. So you need to have a proper instrumentation, or if you're not with instruments, the instruments will be provided to you on table so that you can do it on mammograph. Okay. Have I made my point? Are you clear in your point now?
Yes, ma'am. I just want to ask. So it means we don't have to go to our clinics or wards to examine the patient. We just have to see videos and practice on mannequins.
Yeah. So for this kind of exam, it's not necessary to go to the hospital. Okay. This kind of exam needs a study partner. You can have any of the study partner. You can make her as a role player, and you can practice your station. And similarly, you can be a role player for your study partner, and your study partner can practice on you. Okay.
Okay.
And
Thank you.
and talking to the examiner most of the time. So this, and listening to the role player type of stations. So everything is available in internet for free. You can even read those translated form of information which is available in YouTube videos, so that you can handle role player stations, because there will be large number of role player stations. This is expected in your OSCE. Okay.
Okay, ma'am.
So I think this problem with the presentation. Okay, so so regarding this, so once you have been through this, let me just say there's some problem with the sharing of the slides. Okay, so now if I think this is not working, so I have to go on. Still, I'll try to share it. Okay. So now the static and interactive stations. The static stations are those stations which I told you, there will be a case of breakup of the long case. That will be a connected station, or that will be not connected. In one station, there will be a role player sitting, and you have to talk to the patient regarding like Urdu history, and then you just have to do the proper 10 minutes history and 3 or 4 minutes history, and talk to the patient like, we are going to do this, that. And then the bell rang, and there is written that this is a connected station from the previous station. The examiner is sitting now. The examiner is here to talk about this case scenario. So you will be taken viva. Then there will be the interactive stations with Robert, the way I've told you that it may be like interactive stations linked to the static station. Or there will be a counseling station. So counseling stations are those stations where you'll have to counsel the patient regarding cancer or something, like breaking bad news type, for example, the baby IUD. Okay, so things like that. After this, there can be, something like the report shows that there is a Down syndrome. And now just talk to the role player. So this is a counseling station. So you have to talk to the patient regarding, this is a baby with Down syndrome. What are the cons and pros? Or there is a possibility of having a baby with Down syndrome, and we are going to offer you tests like CVS and amniocentesis, but there are chances like miscarriage, or there may be a possibility that your child doesn't have any Down syndrome. So these are the things which you may encounter. So you should be mastering in handling these kind of stations. Okay. So there will be examination station, like one of the candidates has just asked me this question, that will there be examination stations or not? So there will be examination where the mannequin will be placed, and you have to do, the examiner might ask you to perform UV maneuver, or the gynae examination where he might ask you to perform UV prolapse examination or bimanual plus abdominal examination, things like that. And then there will be separate stations like structure discussions and drops, where random viva discussion topics will be discussed with you. For example, they might give you a scenario in which she has been diagnosed with stage 2 cervical cancer. Now you have to discuss about management options. Now the examiner asks you if she's pregnant also. So now pregnancy with cervical cancer. So you have to talk about that in 10 minutes. So key would already be provided to the examiner, unlike long cases. So there will be like pet questions will be given to them in hand that you have to ask this questions. And if the candidate answers this, then you have to mark this. If the candidate answers this, you have to mark her borderline or full. So there will be a subjective marking also, but more objective marking. So there are increased chances that you might pass this exam in your first attempt. And if you know how to deal it in a right way, the way I've told you, that each station you have to in each station you have to divide it into different 4 domains. Sorry. Okay, so regarding that, so there will be a key. So this will be more like an objective exam rather than subjective exam. So that means there is increased chances of you to pass. There will be a small subjectiveness of the examiner to give you marks. Like if you've been asked a question like what information or what history taking points would you like to go ahead with the patient who has presented with you with the heavy menstrual bleeding. So now you're giving the history points to the examiner. Like I would like to ask the examiner, like I would like to ask the patient, like how long she's been having the heavy menstrual bleeding, and how long she's been having the bleeding. Does she have any problems like, um, um, any cancers running in the family? Does she have any other medical problems like diabetes, or if she has any problems like, obesity? And if I would also like to ask about any drug allergies, I would also like to ask about any, a family history of cancers, or, any examination findings. I would like to ask about the BMI of the patient. So these are the things, if you've been telling the examiner all the points, so the subjectiveness of the examiner might come as that she has not asked this question, so she will be, she should be given borderline. So if the borderline marks they will be giving you, so that will only be 1 or 2. So still, if you get 1 point in information gathering, there are increased chances that you might pass this exam. Am I making sense to all of you?
Yes, ma'am.
Do you have any questions? So,
ma'am, here is one question that you are saying in exams they can ask the UV prolapse. So here now the short cases and then toxicization, the real patient will not be available. So this type of examinations, how we will perform? Are the dummies are there will be no real patient? So how?
Yes. So in UV prolapse, they might give you a uterus-like procedure. Okay. So now they might ask you to tell the examiner regarding that, what stage of the UV prolapse it is, and then how you're going to do the steps on a mannequin. So they wouldn't be necessary that that will be whole of the typical UV prolapse station would have been given to you. They might ask you to, they will be observing you by giving you instruments like this is the speculum examination. Now you have to tell us that how you're going to see for the anterior prolapse or the posterior prolapse. So they will be like more into determining what kind of technique you are applying to diagnose certain type of prolapse in this kind of examination. Okay, so in order to reduce this thing that because they cannot have so much of the mannequins there to be placed for you. So they will be like arranging more role play stations or structure discussion. So I don't think so that they will be like specialized type of mannequin exam, but they might ask you to perform it so that they know that whether you know the technique to diagnose anterior prolapse or posterior prolapse. Okay, so this is how the exam becomes a little bit easier. So regarding that, this is actually so this is how there might be a neonatal resuscitation. So there will be a small doll which will be given to you. So you will be asked to perform the steps of the neonatal resuscitation on that. So there will be a maternal collapse sessions. You will be asked to do the maternal resuscitation steps in front of the examiner and tell the whole guideline according to the steps they are given in the guideline. Similarly, you will be asked about boards, which I've just told you, the labor boards, but there are some other more boards, for example, gynae board. The gynae board might come as different scenarios. So in the different scenarios, they might ask you that there will be a case of ectopic pregnancy, or there may be a case of having a laparoscope. The patient has been planned for lap and dye test, and the third patient would be like having a simple procedure like laparoscopic cystectomy, but she will have a latex allergy. The fourth patient will be admitted for heavy menstrual bleeding due to fibroid. So how you have to prioritize it and what pre-op checks you have to see before taking her to the theater. So this will be a discussion with the examiner in 10 minutes. So this becomes very difficult, sometimes. And this is, you have to deal it because how you do it in your hospital. So this becomes very easier once you're practicing. So then there will be different patients who have to be discharged. For example, the patient with the laparotomy due to ectopic pregnancy, or with the laparotomy due to large ovarian cyst, or with she was a diagnosed case of endometrial cancer. She had a laparotomy and had a total abdominal hysterectomy. Now she's been having, up and down, BP of 90, 60. One of the patient might be having signs and symptoms of paralytic ileus. One of the patient might be having signs and symptoms of hemorrhagic shock. So you have to then justify that I'm not discharging this patient because she's having this. I'm not discharging this patient, I'm shifting her to ICU. So they want you to analyze in this station that whether you are a doctor, if you're a senior registrar, go for a round for the post-op patients, are you the one in census and can prioritize these patients, and which emergency has to be dealt first. Okay. So there might be different emergencies that may be given to you the way I've just told you. And then prioritization, the labor ward prioritization or the gynae ward prioritization. So this might come as, 3-4 scenarios I've just collected. So this might be given to you in 2 minutes reading. You have to, read all the scan this, all the 10 rooms, and then you have to then prioritize in your mind that which room I have to discuss first with the examiner. Okay. So now, in the whatever kind of examination, any questions? So, before I, end up by telling you this extended OSCE system, the books you can read. So the books, the important books, I would suggest you to read, just taking a little bit idea regarding a book which is actually available for MRCG Part 3. Most of the people, when they're appearing for other exams like European Board or Irish examinations, so they also read those big books because they are similar, similar pattern the way now FCPS examination is going to be. So the books are like Lisa Joel and Justin Kunje. So this is a new book where you can have an idea that what kind of scenarios in labor board or prioritization gynae board can come up. Similarly, there is a very good book called Get Through. So this is also a beautiful book where you'll come to know that how usually different stations come and how the structured discussion has to be dealt with. The other thing is that if you want to join our course, in that case, we can also help you out in dealing with these 60, 70 stations. Now, whenever you are dealing a station, for example, in obstetric history, just make up your point like this, which I have mentioned you in front of it. So 7-8 points, you have to make a template of it while talking to the counseling station when you are coming across a role play station, or when you're coming across a structural discussion station. And similarly, there is a PET way of learning those 7 OBS cases, which I've just told you. That may be early pregnancy, or that may be antenatal care, maternal medicine, or the other modules I've just told you. So you just do it like these, effect of disease on pregnancy and effect of pregnancy on disease, and how you have to take the history to the patient, and then keeping this effect of disease on pregnancy and effect of pregnancy on disease, just explain that what medication is she is going to be used, what kind of follow-up treatment she is to be given throughout her, antenatal care plan, and how we have to involve different doctors, and how we have to continue her in pregnancy, what can be the effect on baby, and what needs to be changed to a safer alternative, both for mother and baby. And then contraception, and then, pre-genetic testing if it is to be involved. Similarly, the antenatal care plan. So this is a special template which you need to put in your mind while talking to the examiner and dealing with your obstetric patients. So similarly, the intrapartum care, continued fetal monitoring, hypertension, diabetes, the partogram if she's in labor, an important thing, one-to-one support, active management, and baby assessment by neonatologist. Similarly, the postpartum care, in 5-6 points you have to mention, and you have to keep in your mind, just write it in your copies, because this you have to repeat it for every condition in OBS when you are talking to the examiner. Early breastfeeding, antibiotics, analgesia, VTE, medication review, debrief, contraception advice, follow-up for 2 to 6 weeks, and preconception counseling. So now this was a whole overview of how the 6th FCPS examination is going to be, in front of you. Now, in order to see and in order to practice an example, will there be one volunteer who would be volunteering for a station today?
Which station, ma'am?
Station. So this is how 2 minutes will be given to you to read a station. And who's going to volunteer first?
Ma'am, I want to.
Who is it?
Dr. Sajda.
Dr. Sajda? Okay.
Yes,
so Dr. Sajda, kindly introduce yourself to us.
Ma'am, I have done my residency from Antenatal Hospital, Karachi, and I have passed my theory exam in FAB, and now I'm going to give my Viva examination.
Okay.
I'm from Karachi, yes, ma'am.
Okay, that's good to know. So Sajda, I'm just going to give you a scenario so that everybody understand that how this exam would be and how you have to deal it. Okay, just give me a minute. Can you see the screen? Can you see the screen, Sajda?
Yes, ma'am, but it's not full. It's slideshow.
Okay, so it's actually not going forward. So because of this, I'm not making it a full screen. So now, can you see this scenario?
Yes, I can see.
Okay, so now I'm starting your 2 minutes. Okay.
Okay, please continue the film. Also, she seems to be on the turn.
Okay. So I'm starting your 2 minutes. Just take those 2 minutes, and I will inform you when your 2 minutes are over. And then I will be your patient, and you just have to ask me question in Urdu and explain me that how you're going to take me along in this pregnancy. Okay? Got it?
Yes, ma'am.
Okay, now start.
Discuss with the investigation management plan. If you superintendent to care, she has in the past history of miscarriage, so she seems a little reluctant to reveal an infant. Ma'am, should I have to start? 2 minutes over.
No, 2 minutes are not over. You can take your whole minute. Abhi, it's just 1 minute it has been. Okay.
Okay.
So now your 2 minutes are over.
Okay, ma'am. अस्सलाम वालेकुम.
वालेकुम सलाम.
मेरा नाम डॉक्टर साजिदा है. मैं सीनियर रजिस्ट्रार के तौर पर काम कर रही हूँ. आप मेरे पास आई हैं. मुझे आपसे कुछ सवालात करने हैं आपकी बीमारी के मुताबिक, ताकि मजीद हम आपका इलाज सही तरीके से कर सकें. आपका नाम क्या है?
जी मेरा नाम सफिया शाहीन.
सफिया, आपकी उम्र कितनी है?
जी मेरी उम्र 31 साल.
31. शौहर का क्या नाम है?
मेरे शौहर का नाम शाहीन.
अच्छा, मुझे बताएं आप कितना पढ़े लिखी हैं?
जी मैंने ग्रेजुएशन की हुई है.
अच्छा, कोई जॉब करती हैं?
जी नहीं, मैं इस वक्त हाउस वाइफ हूँ.
अच्छा, ठीक है. शादी कितना अर्सा हुआ?
जी शादी को मेरे अभी 5-6 साल हो गए.
6 साल. अच्छा, बच्चे कितने हैं सफिया आपके?
डॉक्टर साहब एक्चुअली मेरा एक बच्चा हुआ और वो बच्चा जो है जल्दी फौत हो गया डिलीवरी के दौरान, तो अभी इस वक्त मेरे पास कोई बच्चा नहीं है.
अच्छा, कोई बच्चा जाया हुआ है आपका कुछ महीनों में?
जी मेरा जो है एक हमल ज़ाया हुआ है और जी मैंने उसके बाद सफाई करवाई थी. बच्चे की धड़कन नहीं आ रही थी.
ठीक है. और जो आपका पैदा होकर फौत हुआ, कौन से महीने में पैदा हुआ था?
7वें महीने.
सॉरी,
7वें महीने में डॉक्टर साहब.
7वें महीने में. नॉर्मल डिलीवरी थी या ऑपरेशन हुआ था वो?
जी फॉर नॉर्मल डिलीवरी।
नॉर्मल डिलीवरी थी। अच्छा, आपको कोई ब्लड प्रेशर, शुगर, दमा, टीबी ऐसा कोई मसला तो नहीं है, कोई बीमारी तो नहीं पुरानी?
नहीं डॉक्टर साहब, वो जो पिछला बच्चा जो फोर्थ हुआ था उसमें मेरा ब्लड प्रेशर एकदम से तेज हो गया था।
अच्छा, ब्लड प्रेशर बढ़ गया, तो उसके बाद आपने ब्लड प्रेशर वगैरह चेक करवाया था? ब्लड प्रेशर कंटिन्यू तो नहीं रहा था आपको?
नहीं, उसके बाद मेरा ब्लड प्रेशर ठीक हो गया था, लेकिन उसके बाद मैं कभी हॉस्पिटल गई नहीं।
अच्छा, वो डिलीवरी कितने ऐसा पहले हुई है?
जी वो डिलीवरी 1.5 साल पहले।
1.5 साल पहले हुई है, ठीक है। उसके बाद आपने कभी भी चेकअप नहीं कराया?
नहीं।
अच्छा, ठीक है। अभी माहवारी आपको सही आ रही है?
जी
सही
अभी
आ
मुझे
रही थी? आखिरी बार कब आई है?
जी आखिरी बार मुझे ये 3 हफ्ते पहले आई।
3 हफ्ते पहले आई है?
जी सॉरी
अच्छा,
8 हफ्ते पहले आई है।
8 हफ्ते पहले आई है, चलिए ठीक है। वैसे नॉर्मल आती है टाइम से। ब्लड ग्रुप क्या है आपका?
जी मेरा ब्लड ग्रुप बी पॉजिटिव है।
बी पॉजिटिव है, चलिए। अच्छा, मुझे बताएं कि अभी आपने कोई अल्ट्रासाउंड वगैरह करवाया, क्योंकि 8 हफ्ते पहले आई है, तो आपने अल्ट्रासाउंड वगैरह करवाए हैं आपको?
जी डॉक्टर साहब, मैं असल में मुझे लग रहा था कि मेरी माहवारी नहीं आई, तो फिर मैंने किया तो प्रेगनेंसी टेस्ट पॉजिटिव था। और
ठीक
पिछली
है।
दफ़ा जो मेरे साथ हुआ था तो मैं यही अपनी किसी लोकल डॉक्टर के पास चली गई। उसने कहा कि 8 हफ्ते का हमल है, इसने फिर मुझे आपके पास भेजा।
अच्छा, अभी आपने अल्ट्रासाउंड करवाया है कोई?
सिर्फ वही अल्ट्रासाउंड जिसमें बच्चे की धड़कन आई है, बस वही अल्ट्रासाउंड
मैं वही
डॉक्टर
कहना
ने।
चाह रही हूँ कि आपने एक अल्ट्रासाउंड करवाया, उसमें बच्चे की धड़कन है। अच्छा, अब ये हमल आपको खुद ही ठहरा है ना? आपने कोई दवा वगैरह तो नहीं खाई थी ना?
नहीं डॉक्टर
अच्छा, आप चाह रही थी कि हमल ठहर जाए, आप कोशिश कर रही थी उसके लिए?
साहब। जी, जी।
अच्छा, ठीक है। अच्छा, मुझे एक और बात बता, अभी आप कोई दवा वगैरह ली नहीं? फोलिक एसिड लिया आपने?
जी मैंने डॉक्टर साहब, हाँ जी, फॉलिक एसिड शुरू की थी उन्होंने और मैं ले रही हूँ।
ठीक है, ठीक है। हमल से पहले भी ले रही थी?
जी 1 महीना पहले। जी।
ठीक है। अच्छा, कोई लाल गोली, खून पतला करने वाली एस्कार्ट गोली ऐसी कुछ लिया आपने?
नहीं डॉक्टर साहब, अभी तक ऐसा कुछ नहीं हुआ।
अच्छा, बीपी वगैरह चेक करवाया है? अभी आपका बीपी कैसे चल रहा है?
जी ब्लड प्रेशर अभी जो उन्होंने चेक किया था वो तो ठीक था, अभी अभी का पता नहीं।
अच्छा, अभी का पता नहीं। अच्छा, मुझे बता, अभी कोई खून के टेस्ट वगैरह तो नहीं हुए आपके?
नहीं अभी कुछ भी नहीं हुआ डॉक्टर साहब।
अच्छा, मुझे बताएं, अभी आपकी 8 हफ्ते में इस दौरान आपको कोई नीचे से खून तो नहीं छूटा? कोई नीचे से गंदा पानी या पेशाब का कोई मसला, ऐसा कोई कुछ नहीं हुआ?
नहीं डॉक्टर साहब।
अच्छा, अभी आपने कोई हार्मोन्स की कोई गोली तो नहीं खा रही है? कोई इंजेक्शन तो नहीं लगवाया कि प्रेगनेंसी सपोर्ट के लिए, जिसको कहते हैं कि आपकी प्रेगनेंसी आगे चले, इस तरह का आपने कोई तो नहीं करवाया ट्रीटमेंट?
नहीं।
अच्छा, अभी कुछ भी नहीं लेनी, सिर्फ आपने फोलिक एसिड ली है?
जी, जी।
अच्छा, ठीक है। मैं थोड़ी आपसे पिछली प्रेगनेंसी के हवाले से पूछना चाहूंगी। आपका एक बच्चा जो जाया हुआ है, वो कौन से हफ्ते में जाया हुआ था?
जी डॉक्टर साहब, वो मुझे लगता है पहले 3 माह में उसकी धड़कन आना बंद हो गई थी, फिर मुझे दवाई दी और फिर उन्होंने सफाई कर दी।
अच्छा, ठीक है। आप हॉस्पिटल में ही सफाई हुई थी?
जी, जी।
और उसके टुकड़े वगैरह टेस्ट के लिए भेजे थे उन्होंने?
नहीं।
नहीं भेजे थे उन्होंने?
नहीं,
अच्छा,
नहीं।
पहले आपका एक बच्चा जाया हुआ है, उसके बाद ये डिलीवरी हुई है 1.5 साल पहले?
जी डॉक्टर साहब।
ठीक है। अच्छा, ये जो आपके जो आखिरी जो आपका बच्चा पैदा हुआ है 7वें महीने में, जो डिलीवरी हो गई थी नॉर्मल, और जो बच्चा फौत हो गया था, इसमें आपको ब्लड प्रेशर कौन से महीने में चढ़ना शुरू हुआ था?
जी डॉक्टर साहब, चौथे महीने के बाद ब्लड प्रेशर अचानक से तेज होना शुरू हो गया।
ठीक है। आपने अपना नाम दर्ज करवाया था हॉस्पिटल में? बाकायदगी से दिखा रही थी?
हाँ जी डॉक्टर साहब।
दवा ले रही थी आप?
जी।
अच्छा, ठीक है। और आपका ब्लड प्रेशर बढ़ा तो नहीं था, खून तो नहीं छूटा था जब ये 7वें महीने में जो डिलीवरी हुई, आप दर्दों के साथ हॉस्पिटल गई थी, या बच्चा
सर
डिलीवर
मेरे
क्यों
बच्चे का
करवाया था
पानी
साथ?
खत्म हो गया था।
बच्चे का पानी खत्म होगा, उन्होंने नॉर्मल डिलीवरी करवाई थी। डिलीवरी के बाद बच्चा जिंदा रहा था आपका?
नहीं बच्चा पेट में ही फोत हो जी, जी। उसकी धड़कन बिल्कुल ठीक नहीं आ रही थी और फिर बच्चा बस 1 या 2 घंटे के लिए जिंदा रहा, उसके बाद नहीं बच
उसके बाद चलो ठीक है, चलो ठीक है। उसके बाद आपको कोई मसला तो नहीं हुआ था खून छूटने का, या कोई ऐसा तो मसला नहीं हुआ था?
नहीं।
अच्छा, आपको कोई और कोई मसला, शुगर का कोई मसला तो नहीं है, या कोई और खून जमने की बीमारी आपको या आपके खानदान में किसी को? हेलो?
नहीं डॉक्टर साहब, मेरी बहन को शायद कोई मसला था, उसका शायद थ्रोम्बोफिलिया कोई प्रॉब्लम बताई थी।
मैं वही पूछना
ये
चाह रही
मुझे
हूँ, आपको
याद
कोई ऐसा खून जमने या कट लगने से खून ज्यादा जल्दी बह जाता हो, या ऐसा कोई मसला तो नहीं है आपको?
नहीं। नहीं।
अच्छा, ठीक है। और मुझे ये बताएं कि जोड़ों में, छोटे जोड़ों में दर्द होता हो, आप बाहर निकलती हो, धूप निकलती हो तो आपको चेहरा लाल हो जाता हो ज्यादा, ऐसा कोई मसला तो नहीं है?
नहीं। नहीं।
चलिए ठीक है। आप मुझे फैमिली में कोई एबनॉर्मल बच्चे पैदा हुए, कोई ट्विंस बच्चे पैदा हुए, फैमिली में किसी को खून का कोई मसला हो, थैलेसीमिया या ऐसा खून लगने की बीमारी, ऐसा कुछ मसला?
नहीं।
अच्छा, कोई आपका ऑपरेशन वगैरह तो नहीं हुआ? सिर्फ एक सफाई आपने बताया है ना?
जी नहीं है, अभी सिर्फ एक ही सफाई हुई है जी।
अच्छा ठीक है। आप छालिया, पान, गुटखा, स्मोकिंग ऐसा कुछ वगैरह तो नहीं करती हैं?
नहीं।
आपको किसी दवा से एलर्जी हो?
नहीं।
अच्छा, आपने कभी बच्चेदानी का अल्ट्रासाउंड करवाया, उसमें कोई रसौली ऐसा कुछ बताया हो?
नहीं डॉक्टर। डॉक्टर साहब मुझे ये
अच्छा
बताएं कि मेरा अभी क्या होगा, क्या
अच्छा ठीक है। अभी
कैसे?
आपने मुझे जो हिस्ट्री दी उसके मुताबिक मैं आपको सिर्फ ये कहूंगी कि आपका एक बच्चा ज़ाया हुआ है जो 3 महीने में आपने बताया था धड़कन रुक गई है, और दूसरा ये कि एक आपका अर्ली प्रेगनेंसी डिलीवरी हुई है जिसमें ये था कि ब्लड प्रेशर बढ़ गया था और पानी खत्म हो गया था। अब आप 8 हफ्ते के हमल के साथ मेरे पास आई हैं। सबसे पहले तो ये कि इस प्रेगनेंसी में भी आपको ब्लड प्रेशर बढ़ जाने के खदशात हो सकते हैं, और इस बच्चे में भी पानी खत्म होने के भी चांसेस हो सकते हैं। तो सबसे पहले तो ये कि मैं आपको ये फोलिक एसिड कंटिन्यू करवाऊंगी, और आपसे कहूंगी कि आप अपने बीपी बाकायदगी से चेक करवाते रहे। आप किसी बड़े हॉस्पिटल में अपना नाम लिखवाएं। पीली गोली सॉरी लाल गोली है इस कार्ड की फिलहाल मैं आपको शुरू करवा रही हूँ, ताकि आपका बीपी जो है वो नॉर्मल रहे, और जो है आप हमें बाकायदगी से हमें दिखाती रहेंगी। और जो है अपने सारे टेस्ट आप खून के सारे टेस्ट करवाएंगी, और जैसे जैसे हम आपको बुलाते रहेंगे आप उस विजिट पर हमारे पास आएंगी। हम आपका एक नॉर्मली स्कैन करवाएंगे जिसमें बच्चे के नुक्स वगैरह देखने के होते हैं, उसमें कोई नुक्स वगैरह तो नहीं है बच्चे के। अगर सब सही रहा तो हम आपकी प्रेगनेंसी को कंटिन्यू करेंगे। हम आपके शुगर के टेस्ट भी करवाएंगे, हर विजिट पर आपका बीपी वगैरह चेक होगा, और जो है शुगर और इन सब चीज़ों का आप ख्याल रखेंगी। अगर कोई भी अलामत है जैसे आपको सर में दर्द होना, आंखों के आगे अंधेरा आना, मैदे में जलन या सीधी तरफ पे दर्द वगैरह होना, या आपके पैर सूजना, या आपको पेशाब कम आना, या पेशाब गाढ़ा आना, या झाग वाला पेशाब आना, ऐसे कोई मसला हो तो आपको फौरन हमारे पास आना है। या आपको लगे कि आपका ब्लड प्रेशर बढ़ रहा है तो आपको फौरन हॉस्पिटल आना है। हम कोशिश करेंगे आपकी प्रेगनेंसी को कंटिन्यू करें जब तक बच्चा पूरा बन जाता है। 37 हफ्ते तक आपकी प्रेगनेंसी को कंटिन्यू करेंगे। इस दौरान हम आपका बीपी चेक करवाते रहेंगे और सारी चीज़ें देखते रहेंगे। अगर कोई मसला वगैरह हुआ या ब्लड प्रेशर बढ़ा तो हम आपको ब्लड प्रेशर की गोलियां भी शुरू करवाएंगे, और साथ साथ हम आपके अल्ट्रासाउंड वगैरह भी करवाते रहेंगे फ्रिक्वेंटली, क्योंकि पहले आपने बताया था कि बच्चे में पानी कम हो गया था। तो हम आपके जो है हर महीने महीने अल्ट्रासाउंड भी करवाएंगे, ये देखने के लिए कि बच्चे की ग्रोथ सही से हो रही है कि नहीं हो रही है। आपको खुद भी बच्चे की हेल्थ का ख्याल रखना होगा, और हम आप पूरी कोशिश करेंगे कि आपकी प्रेगनेंसी पूरे 9 माह तक आगे चले, और बच्चे में और आपको कोई मसला ना हो ब्लड प्रेशर शुगर का, और जो है बच्चे में भी कोई मसला ना हो, ना पानी का, ना कोई इसकी ग्रोथ का कोई मसला हो। अगर सब कुछ सही रहा तो हम आपकी डिलीवरी करवाएंगे। हम कोशिश करेंगे कि आपकी नॉर्मल डिलीवरी हो, क्योंकि पहले भी आपकी नॉर्मल डिलीवरी
डॉक्टर साहब
हुई है।
मेरी बहन को भी ये मसला था, क्या उसकी वजह से तो नहीं हो रहा?
नहीं ऐसा ब्लड प्रेशर का आप कह रही हैं?
नहीं, मेरी बहन को कोई थ्रोम्बोफिलिया है, वो कहते थे कि शायद कोई मसला
देखिए
है।
हाँ हो सकता है। वो आपने एक जीनियाती मसला होता है कि जो खानदान में भी बीमारी थी, किसको खून की जमने की ज्यादा सलाहियत होती है, तो आप क्योंकि वो आपकी बहन के तो आपको भी हो सकता है, लेकिन हमें उस दिन पहले आपके टेस्ट करवाने चाहिए थे। लेकिन अब क्योंकि
डॉक्टर
आप
साहब मुझे
प्रेग्नेंट
ये
हैं तो वो टेस्ट
बताइएगा
नहीं।
कि मुझे किसी डॉक्टर साहिबा ने, जहाँ मैं पहले चेक करा रही थी, उसने कहा था
जी
कि
जी।
कोई नीचे टाँका लगना चाहिए।
अच्छा ये ठीक है। उसके लिए हम आपको जो अल्ट्रासाउंड करवाएंगे ना, उसमें हम देखेंगे आपको जो है ना बच्चेदानी की मुंह की जो
सर मेरे
लेंथ
साथ
है वो
ऐसा
कम
क्यों
तो
हुआ है?
नहीं है।
So Sajda,
देखिए
your
इसमें
time is already up. Now you're exceeding your time.
ओके ओके। अच्छा ये तो इसमें आपका कोई कसूर नहीं है, क्योंकि आपके बच्चेदानी के साइज हम देखेंगे। अगर वो कम हुआ तो देखेंगे कि जरूरत है टाके की कि नहीं। वरना अगर सब कुछ सही रहा तो फिर जरूरत नहीं होती है टाके की। और इसमें
Okay, now
आपका कोई
close
मसला?
your station now. Or close your
यस
station.
यस।
How are you going to close your station?
अच्छा ठीक है। अच्छा अगर आपको कोई और मज़ीद सवालात करने तो आप मुझसे पूछ सकती हैं, और मैं आपको नेक्स्ट विजिट पर बुलाऊंगी। आपको बाकायदे से हमारे पास आना है, और बस मैडम।
Okay, thank you. So wonderful, Sajda. You know the basic template of the station, how you have to deal. Are you studying from somewhere who has given you the
नो
exam
मैम,
like?
ये जस्ट प्रोवाइडेड बुक्स इन द मार्केट ऑफ हिस्ट्री।
Okay, have you taken any help from somewhere? Sorry, I couldn't listen you.
नो नो
Okay, so you were very wonderful. I've come across.
Madam, but I think the negative point from my side was that I was completely focused on the history. Although I know
Yeah.
I have to go on the management as well, And the other thing is that I was, as she told me that she has a history of PIH, so I was just focused on PIH. As you just put on question on me, the cervical incompetency, so I just missed on. Although
and that you came up
we
when the time was about to finish, and I prompted you that you're missing the
yes,
main.
ma'am, that was the thing. So we have to be
So you
open-minded.
also ignored one point. She gave you a very important point of thrombophilia screen, which had been
Yes,
done to
ma'am, you
notice.
asked. So.
And so this is how you're going to do the station, and with the time lash, like limited time, you forget to do the main things which is actually demanding the marks. Acha,
Yes,
ek aur
ma'am.
cheez which you have missed, anything which you would be thinking that what else you have missed in the station?
Ma'am, she has history of miscarriages in DNE, so maybe shimmers or placenta abruption, maybe like that. Or any vaginal discharge, So
anybody from the participants who can prompt that what else she has missed? Anybody from the participants?
APLA workup or what else?
Yes, you missed it in the management, but you were still very wonderful because you tried to cover, you were like speeding to cover most of the things, but एक और चीज जो इस स्टेशन की डिमांड थी. Can you read the scenario, Sajda, again?
Yes, ma'am. Mrs. Safia Shaheen has been here at 8 weeks for antenatal care plan. She has in the past history of miscarriages, which she seems a little reluctant to reveal, and one preterm delivery.
Okay, so now question mark has been given.
Miscarriages means heparin, madam.
Yeah.
Scarred
So
heparin,
she
because
gave you
it
only
is a history of thrombophilia. Yes. I'd note
so she
down.
gave
Okay,
only,
we should have to.
Yeah,
Heparin
you
as well.
explore it, because there was one more miscarriage I had in the previous history.
Okay.
And that is the reason I prompted you that the doctor who's referring you here, so she's saying that she has a history of miscarriage, which she seems a little reluctant to reveal. You didn't try to explore it because you were so much, speedy in your, you had a mind of covering the whole station that you forgot to even, dislodge this
Madam,
point.
it was in my mind, but the thing was that I was just saying if she has a history of PIH, maybe because of that she has preterm delivery, and I don't have to go for. I just discard as card none, and I didn't go to Clarkson as well. I
So actually,
if she was para
quite
0 plus C, maybe it was. I will tell you the. I would tell you the injection Clarkson. But if it was para 0 plus C, she was para 1 plus 1. Although okay, but I was.
But I gave you the history that. Yeah. So, so Sajda, actually, I gave you the history of oligotracheosis and heteromeos and early preterm delivery, and because of this, the baby died. So your mind started, and the blood pressure history. Okay? So your mind started moving towards managing the patient in the line of high blood pressure, placental insufficiency, things like that. You didn't come to the cervical incompetence, and you didn't try to explore more reason that why the cervical incompetency came. You only asked one question: infections. That's it. You didn't ask any other thing like injury to the cervix. Maybe she had
surgery,
lens. And you didn't ask about the main important thing which I'm stressing on. She had one more miscarriage in the past, and that was when she was 14-year-old. She was raped, and she was reluctant to reveal it to the doctor because she's married now and she didn't want this thing to happen. So because of this,
these are the hidden histories. If I just how can I ask? That means she had miscarriages 3 months, and she told me that only she has miscarriage. Heartbeat was stopped then. So how we can go to the more hidden histories like that?
Now that's a good question. So now what would you do? So you started the template very well. I was like saying now she's the passing candidate. She knows that how to handle the station. But you missed this because you didn't follow the exact template. Now what you have to do is that you'll have to say, "Assalamu alaikum, मेरा नाम Dr. Asma है. मुझे जो इंस्ट्रक्शंस जो पेपर मिला है या मुझे जो इन्फॉर्मेशन प्रोवाइड की गई है उसमें मैं दे सकती हूँ कि आपका नाम सफिया शाहीन है. ये क्या करेक्ट है या ये बिल्कुल ठीक है?" So now she's going to say yes. Now you will say that आप अपने आप को कैसे बुलाना चाहेंगी, तो वो बताएगी कि प्लीज कॉल मी मिसेस शाहीन या प्लीज कॉल मी मिसेस सफिया. So you say, okay, so Mrs. Shaheen, जो information, please मुझे आप सारदा कह सकती हैं या डॉक्टर आसमा कह सकती हैं. सफिया, जो information इस वक्त मेरे पास आई है, उसमें बताया गया है कि ये आपका 8वां हफ्ता हमल का चल रहा है और इससे पहले आपका एक हमल जाया हुआ है और एक डिलीवरी भी हुई है जो वक्त से पहले हुई थी. क्या ये सब information बिल्कुल ठीक है? कि यस, यू आर नाउ कंफर्मिंग कि ये राइट पेशेंट है या नहीं. उसके बाद आपने उसके बाद कहना है कि मिसेस सफिया, क्या आप मुझे मजीद इंफॉर्मेशन देना चाहेंगी? नाउ if she's reluctant, she is not going to tell. Then then you have been given this information that she has been hiding something. Now just say, now take a confidence of the patient and say, Mrs. Safia, जो भी आप मुझे बताएंगी वो सिर्फ आपकी और मेरे दरमियान में रहेगा और वो और किसी को नहीं बताया जाएगा जब तक आप मुझे इसकी इंफॉर्मेशन नहीं देंगी. आप मुझे सब कुछ कॉन्फिडेंस में लेके बता सकती हैं क्योंकि ये चीजें आपकी मैनेजमेंट के लिए बहुत इंपॉर्टेंट है. Now she will say, okay, so doctor, in the past, what happened, things like that. Okay. So now you will say, and if she doesn't give you the answer, then still make her, give her a confidence कि अगर आप चाहेंगी तो हम इस इंफॉर्मेशन को आपके रिकॉर्ड पे भी नहीं लिखेंगे, ये सिर्फ उस रिकॉर्ड पे लिखा जाएगा जो सिर्फ डॉक्टर्स के दरमियान में रहेगा. So that the next doctor who's going to manage you is going to know that actually in what lines we are managing. Okay. So now she will give you the information कि हाँ मेरा रेप हुआ था और उसमें ये क्या हुआ.
So first we have to give the open questions to the patient that what she wants to tell us about.
So first you have to take her. Yeah. So actually, so now now because this was actually the hidden agenda of this station. This is actually something which I'm giving you the most difficult one. I don't think so in FCPS examination they're going to make all these things more difficult for you, but you need to be so prepared that if this sort of a thing comes in, in exam, you should know how to handle this station. Okay. So this is how you're going to take out, or whatever happens, in your ward, things like that do happen in your ward, right? So how you deal it? Do you say it like that in a very softer manner, that whatever you're going to tell me is going to be in between you and me. I'm not going to tell it to anyone unless you are going to give me permission to. And this information will only be told to those who are involved in your care plan and will remain confidential and wouldn't be told to any persons you want us to. Okay, so now the patient will feel more confident. And why we want this information? Because we want you to not to have such kind of an incident or event again to happen in this pregnancy. Okay. So now you're saying it like this, and now the patient is going to give you all the information you want to acquire. Now tell her what actually happened. So this is the open question you are giving to the patient. So now the patient is going to tell her, I'm 13-year age, मैं 14 साल की थी, मेरा रेप हुआ और मेरे माँ बाप ने मतलब we had to take this difficult decision और हम आ गए, उन्होंने मुझे इंड्यूस किया और मेरी काफी देर तक मुझे गोलियां देते रहे और फिर उसके बाद दाई थी जिसने हैंडल किया मुझे और उसने सफाई की और सर्वाइकल इंजरी की. Okay,
madam, do we have extra mark for this if we do we have extra mark for that if we dig out this type of point?
Yeah. How? Because I told you that communication with the colleagues and communication with patient. So these were the different domains on which you're going to be tested. So when you're talking like this to the patient, so you are going to get star on communication with, patient. Okay.
So we are above borderline.
So this is, or borderline. So examiners being trained on these lines. Examiners are also being trained now. So they've been given the workshops to deal with you so that you can be you can be marking they will be marking you on these domains. So I would like you to all be very vigilant in making your communication skills to the patient very strong, that this is something which you don't want to lose, because now the game is in your hands, not in the examiners. Okay.
Okay.
So the second thing is this: when she gives you the history of miscarriage, and then you can tell, okay, can you tell me more about your second miscarriage? What happened? So one of the beauty of this exam is that जब आप लॉन्ग केस में पेशेंट से वाइवा ले रहे होते थे तो वो अपनी सहारे रोने रोती थी और मैं उनसे टारगेटेड क्वेश्चन की तरफ लेके आना पड़ता था ताकि हमारा टाइम ना जाए. बट हियर दिस इज नॉट अ रियल पेशेंट, दिस इज अ रोल प्लेयर हु इज टॉकिंग टू यू. अब रोल प्लेयर तो वही बताएगा जो उसे इंस्ट्रक्शंस मिली हुई है. तो जब आप ओपन क्वेश्चंस उसके साथ करेंगे तो रोल प्लेयर आपको वही इंफॉर्मेशन देगा जो उसको इंस्ट्रक्शंस में बताया गया था. So now that will be a very easier for you to extract all the information by asking open questions. Okay.
Fine.
Start asking open questions initially so that you save your time. So your questions were very good, but those were very targeted. So that is the reason you completed your information gathering in 6 minutes. So you had only left with 4 minutes for talking to me regarding investigations and for management. Because of this reason, you couldn't, you couldn't manage your whole case. Okay. Otherwise, you were perfectly doing right. And when I prompted you, so you came up with the cervical, cerclage and things like
yes, ma'am. Yes, I noted
okay,
that.
okay. So after this, you explored about miscarriages. Now you should have asked about. Can you tell me more about the delivery that happened? तो उसमें मैंने बताया कि बच्चे का पानी खत्म हो गया था, blood pressure तेज था, okay, क्या दवाइयाँ दी गई थी और blood pressure you ruled out. Yeah, that was a very good question. And then after that, you ruled out about yeah. So now the question would have been any infection. अच्छा, उसके अलावा any injury, cervical biopsy you missed, any screening before, any problems like family history of concern. Regarding when you were asking this question, I was about to give you information, but you didn't let me because you were so fast. So whenever you're asking,
due to shortage of time, I was
I knew that. So now with the practice of time, practicing all stations in 10 minutes, now you will try to practice it with the study partner. Okay, so now you'll come to know that how you have to manage this in 10 minutes and how you have to exclude out time, and at the same time you have to listen to your patient. Okay, so don't even so that you don't miss the important information. So I had to give you family history of diabetes to my mother and father. So because of this, she's Asian, she's having a family history, and because of this, now she's been increased, has a tendency to be given OGTT test.
OGTT test. Yes.
So you missed this important applied knowledge. OGTT you missed. You missed cervical screening. You missed cerclage. You missed, MTT. So multidisciplinary team. The most important thing while managing this station is that whenever you are dealing a station, you're not a consultant yet. You're a senior registrar even after getting this degree, right? So why are you managing this case on your own? Why are you forgetting the communication domain with the colleagues? Okay, let me just show you the domain diagram again. So when I was explaining you regarding the breakup of the station, while I was explaining you that how this station has been torn up, or this has been breakup has been given a break of 5 domains. So this is how you're missing your domains in your station. I don't know where this slide has gone. So this slide must have been here. Let me just go back. Yeah. So now you missed communication with patient, you missed communication with family, and you missed communication with colleague. Okay. So borderline in three domains. So you see, and you were thinking that you did a very well station, the stations went well. Overall, your station went well, but it was overall borderline. So when you're doing all the station borderline, so you are actually, all stations, if you're doing this way, and you're missing your domains, whatever you're telling me extra is not making you any difference to, have a gold medal or have a percentage that makes, more towards passing exam. Okay, so this is how candidates fail exam, and this is how when they say come out and they say I've told everything, but still they come up with the result like fail or borderline or things like that. So if you do these things and you do not tell extra knowledge, and you pass like 73%, 83%, even you get a 90%. So this is a very easy pattern through which you can even get a gold medal also, right?
Okay.
With practice. So let's do, so this was how you're going to do your role play session. So this is now complicated type of a role play. So it's not like the one you had it in IMM. This is something which is through which they are going to have a view regarding how you will be dealing the patient in terms of taking history, because this is the short form of long case. इसी तरह long case होता था, long case में आपने information निकाल के एग्जामिनर के पास जाना होता था और पता चलता था आपने तो एक मिसकैरेज नहीं निकाला, और एग्जामिनर के पास चार्ट होता था और उसमें पता होता था कि इसमें या एग्जामिनर ने पहले एक वाइवा लिया होता था पेशेंट से कि उसको हिस्ट्री पता होती थी कि she also had one miscarriage. Okay, so now in the applied clinical knowledge, you had to discuss with the examiner multidisciplinary team, where you had to involve the medical specialist, where you had to involve the the radiologist or the laboratory imaging doctors, you had to involve the hematologist also at the same time, because uski behan ko thrombophilia S hai. Ab usko jab wo delivery ho jayegi, then she will be on low molecular weight prophylactic dose. But after the delivery, because she has a very, very strong risk factor of having family history, and once, previously she had this history, so she will be risk assessment for VTE throughout her pregnancy also. And also after the delivery, she will have some thrombophilia testing, and this has to be decided about that what kind of thrombophilia testing she will be tested on by the hematologist. Okay. A special consultant, your consultant is going to see her throughout her pregnancy. She will be written in the antenatal care plan of high risk care case. And she will be offered OGTT. So we would need a diabetic team, collaboration also in that case. So you've also got, and she's already having, fourth time she's getting pregnant and she doesn't have any issue yet. So she will be so much emotionally, depressed. So you need a psychological support at the same time. So these are the psychologists. So 5 people are here to give her a management throughout her pregnancy, right? So this is the communication with colleague. So now management. So now we are going to book you. हम आपको book करेंगे अपने consultant obstetrician के साथ, और आपके कुछ टेस्ट करेंगे, और हम आपको जैसे आपने कहा कि we're going to start you on Loprin. We'll be starting on this folic acid, and we will be arranging a test called OGTT, especially किसी glucose पीने वाला test है जो आपकी sugar को check करेगा, और फिर उसके बाद we're going to talk about her about the 7 to 9 week early pregnancy scan, जो उसका पहले उसकी किसी डॉक्टर के पास हुआ है. Now you have to arrange your own scan with the radiologist, और उसके बाद dating scan, फिर dating scan के बाद anomaly scan, और फिर उसका अगर OGTT negative आता है, repeating OGTT at 24 to 28 weeks again, and then in all of the 26 weeks onward serial scans, and then with the serial scans she will be kept about कि बच्चे का फ्लो सही चल रहा है या नहीं चल रहा. Offered a normal delivery 36 weeks onward. इसी से serial scans में we are going to see कि उसकी cervical neck की जो है लेंथ कितनी है, और उसकी जो है सर्वाइकल लेंथ के मुताबिक then we going to decide about certain लेंथ. अगर उसकी कम आती है तो स्टिच, और स्टिच जो है वो 34-36 वीक्स पे रिमूव होगा. और फिर अगर उसकी प्रीटर्म डिलीवरी होती है तो उस केस में तो क्या करना पड़ेगा, वी हैव टू रिमूव द स्टिच, स्टीरॉइड कवर देना पड़ेगा, और इन केस अगर शुगर होती है तो हमें शुगर की दवाइयों पर डालना पड़ेगा. ब्लड प्रेशर के लिए ब्लड प्रेशर की दवाई का आप क्वेश्चन पूछ रहे हैं, then do ask about asthma, because you have to start on labetalol. You have to write about asthma. So this is a patient safety you're missing. Okay. So then after the delivery you'll have a normal delivery. Normal delivery इसकी कहाँ होगी, अस्पताल में, जहाँ पे CTG उसके बच्चे की धड़कन चेक होगी, और बच्चा डिलीवर होने के बाद बच्चे वाला डॉक्टर उसको देखेगा, और उसके बाद उसको उसके ब्लड क्लॉट्स के लिए रिस्क असेसमेंट की जाएगी कि उसकी फैमिली हिस्ट्री है पोस्टमार्टम डो फैक्टर 10 डेज के लिए उसको लो मोलेक्युलर वेट हेपरिन भी मिलनी चाहिए, राइट. सो फिर उसके बाद उसको जो है हम डिस्चार्ज करेंगे, और कॉन्ट्रासेप्शन एंड देन ब्रेस्ट फीडिंग, यू हैव टू डिस्कस ऑल दीज थिंग्स. ओके, एंड देन यू कंप्लीट द ट्यूशन. So this is how you do this station, and this is how if you're unable to complete this, bell rung, now you come up with the next examiner, and whatever I've told you in English, do it with the examiner in English as a structural discussion. Now this is the second station. Who is going to be a volunteer for the station? Is it Sajda who will be doing this, or somebody else would like to have Adila, Momal Gyan, Misbah, Kiran, Neer, Norina, anybody would like to have a go? Shaista, Shagufta, Saliha. Please guys, this is the time you can try for this, because now making mistake, I am sure Sajda is not going to forget this station.
Yeah, thank you, ma'am.
So anybody else would like to have a go, or do I have to continue with Sajda? Rosina, are you happy to go along with the structured discussion? Dr. Rosina? Hello? Rosina, are you there? Okay,
Ma'am, this is a structured one. This is a structured one.
Yeah.
Thank
So
you, ma'am.
who is the other person who talked to me?
Yes,
So,
madam, can I try?
Who is this one?
Afshin.
Afshin. Okay, Sajda, thank you so much. You were a wonderful candidate. I would love to have another station with you some other time. Let's just give a other person time. So keep it up and add up these points and prepare your scenarios the way I've just told you. Okay.
Thank you. Thank you.
Okay. So Afshin. So now the next station is in front of you. I'm going to set a timer for 2 minutes. And this is going to be a total viva station, which we call a structure discussion station with the examiner. Okay.
Yes, madam.
So make your notes. And one of the important, most important thing how you can excel in this exam is that once the 2 minutes have been given to you, never be so impatient to talk to the examiner. Just be very patient, take a pencil and copy, and make your the domains which I've just mentioned, you guys: communication with colleague, communication with family, communication with information gathering, patient safety. So write it in 5 different boxes: 1, 2, 3, 4, 5, and as soon as you come up with the bell rungs, you see a station, 5 domains, just write it quickly in your notes, and just see that this is read the scenario. Just write Mrs. Faria Shaheen, and she's 31-year-old, 3 consecutive second trimester miscarriage. Important points. Now I'm going to talk about this information gathering. I'm going to ask this information colleague. I'm going to tell the examiner this. Make your quick notes and then try to talk to the examiner. Okay?
मैडम यहाँ पे रोल प्लेयर नहीं है, जो मैंने हिस्ट्री लेनी है वो मैंने एग्जामिनर से ही पूछना है, जो उससे रेलेवेंट क्वेश्चंस मुझे चाहिए.
Yeah. So this will be a structured discussion. The scenario has been given to you. Examiner will be your, will be providing you information. जैसे जैसे viva चलता जाएगा, so I would like to ask you questions, and then you just have to tell me the important question points you want to ask to the patient, and then I'll tell you that this patient has this. Then the exam we will take forward the scenario. Okay.
Yes, ma'am.
So I'm starting your 2 minutes, and yeah, start. Make your notes. The bell will ring, and then you'll have to start. Now your time is up.
Yes, ma'am.
I've started your time now, and so this is how. So the question is in front of you, Mrs. Shaheen, Faria Shaheen. Can you please summarize this case for me, and please tell me what information you're going to get from this patient, and what examination would you like to do for this?
Madam, I want to know how, since I want to get some information regarding patient, how since patient is married. Is it
Okay.
first marriage?
Okay, just Afshin, I'm interrupting you because this is the first time you've been doing this to me. Whenever you're
Yes,
starting the station or discussion with the examiner, introduce yourself. Okay, so this is actually making a good impression of you with the examiner. Just say that, hello, hi, अस्सलाम वालेकुम, मेरा नाम डॉक्टर अफशीन डैश डैश है और मैं एक एग्जाम कैंडिडेट हूँ और I'm ready for the structural discussion, or I'm ready for the viva. Okay. So this is how examiner is going to come to know that she is actually, she's worth talking to, right? So now start again. Start again.
अस्सलाम वालेकुम मैडम, मेरा नाम डॉक्टर अफशीन है.
So don't say madam. Don't say madam. Don't say madam. Okay?
अस्सलाम वालेकुम, मेरा नाम डॉक्टर अफशीन है, and I'm the viva candidate of this exam. Can I start?
I'm ready for structured discussion. Yeah, I'm ready for viva.
I'm ready for viva. Should I start?
Yeah. So the case is in front of you. Can you please just summarize this case and tell me what information gathering would like to go ahead for this patient and what examination?
Yes, madam. I would like to ask certain questions.
Just remove this madam word from your mouth.
Sorry.
From now on,
I
okay?
would like to ask certain I would like to ask certain questions so that I can, before that I can summarize this case. Should I ask?
Yeah, please go ahead.
How is the patient is married? How long since the patient is married?
Okay. Just ask the questions and I will give you information at the end.
Is it consensuous marriage or non-consensuous marriage?
Okay.
And
Is there anything else you'd like to ask?
any comorbidity, diabetes, hypertension, asthma, SLE, any known
Okay.
medical disorder? And is there
Okay.
any history of cervical cerclage? Is there any history of cervical cerclage in previous pregnancies? Any history of cervical surgery, cervical conization done in past? Any
Okay.
history of vaginal discharge before these miscarriages, or and the event regarding these miscarriages? And how was the termination was carried out? It is spontaneous, surgical, or medical? And later on, the products of conception were sent for histopathology or not?
Okay. So regarding that, your patient just didn't had any problem. She just had 3 second trimester miscarriages, and there's no history of any cervical surgery which has been done to her. And she, yeah, and there is no other comorbidity till so far for which she's been given any treatment right now. And she's been married for about 3 years. Sorry, 5 years.
Any family history of thrombophilias and any event of stroke?
Okay, is there anything else you would like to ask or do examination for?
Madam, then I would like to ask her BMI in examination, vitals.
Okay, so the BMI is normal, the vitals are normal.
Madam, any per-abdominal examination and bimanual examination, is there any pathology? Is there any positive finding?
The investigation has been done and the investigation shows this report.
Yes.
Now, please tell me what would you like to do for this patient?
Madam, first of all, I would like to counsel my patient. Will involve, would like that some relative and her husband may present with her. And then I will tell her the probable cause of her miscarriages. That is the uterine anomaly, and that is treatable.
So how are you going to treat this? And tell me how and what are the different, evidence-based studies which shows that this condition is treatable.
My corneal uterus.
So what evidence says that this is treatable and how you're going to treat her? Yes, you're going right. So do you think that this is a congenital abnormality?
No, madam, it's not a congenital abnormality. It's a uterine anomaly.
So is it not a congenital one?
It could be a congenital one, but it
So
could
can you
be
classify
multiple
it? Can you classify this?
Sorry, madam, I couldn't.
Okay. Do you think it is necessary to investigate for uterine abnormalities in all cases?
Yes, no, madam, not in all cases, but in the most probably second trimester miscarriages, one of the most common cause of second trimester miscarriages is uterine anomalies.
And what are the limitations of different types of investigations which you're going for if you're going to treat them? And what are these investigations?
First of all, as like the pelvic ultrasound that is already available, hysterosplangiogram should also be could also be taken, and hysteroscopy.
Okay.
And
So,
laparoscopy.
Okay. Any other?
And yes.
What's your what is the role of Sono, hysterography, and MRI in this case?
Yes, madam. MRI and so through Sono, hysterography, and MRI, we can also see this type of uterine anomaly. Also, I missed that.
And what are the limitations with 2D ultrasound and HSG, hysterosalpingogram, if we use this as a first line to diagnose this with these anomalies?
Yes, madam. Ultrasound, pelvic ultrasound in hysterossalpingogram has limited the specificity in diagnosing these uterine anomalies that are missed on hysterossalpingogram and pelvic ultrasound, but this should be picked up on MRI and sonohysteroscopy.
So I asked you previously, and I'm repeating this question again. So what evidences are available for treatment of this congenital and acquired uterine abnormality in recurrent pregnancy losses?
Sorry, madam, I don't know.
Which investigations are you going to offer to diagnose these acquired uterine abnormalities?
Madam, I can offer my patient, first of all, pelvic ultrasound, then MRI, and hysterospingogram, hysteroscopy, and laparoscopy.
Okay, so if there is a uterine septum, what are your management would be in this case?
Madam, if there is any uterine septum, then through hysteroscopy, after taking consent and discussing with my patient the different treatment options, I would like to do, I will remove that septum through hysteroscopy.
What about if there is some mucosal fibroid?
Madam, if there is submucosal fibroid, if the size is less than 5 centimeters, it could also be removed hysteroscopically.
So what are you going to tell this
Depends upon
patient now if she is now pregnant and she wants to avoid this thing to happen in a pregnancy? How are you going to take her along till delivery?
Sorry, madam, please, can you please repeat question?
Okay, now if she gets pregnant with bicornuate uterus, so how are you going to manage this pregnancy?
Madam, if the patient get pregnant, then I will, first of all, I will counsel my patient about the high-risk nature of the pregnancy due to this uterine anomaly. We'll discuss a different different risks that she could encounter during the period. I will provide her with antenatal care. We'll do her frequent antenatal visits. But at that time, this मैडम इसकी ट्रीटमेंट नहीं इस टाइम हो सकती एंटीनेटल केयर ही पेशेंट को प्रोवाइड कर सकती है if the patient becomes pregnant with this uterine anomaly.
So you think this is the only reason she has been having miscarriages?
Madam, this could be one of the reasons of having miscarriages, while all other investigations, you didn't provide me other investigations in which I need her OGTT, I need her cervical length, and any uterine pathology, any submucosal fibroid, and madam, her TSH level.
Yeah, your time is up. Now you're coming to the point. Now you've started telling me all the points, which I was trying to take you or trigger you onto. So now your time is up. Anything else you would like to tell me regarding this patient?
Madam, I need all these investigations so that I could comment on. Then I will definitely plan her treatment plan and will find her cause of recurrent miscarriages. But uterine anomaly could be one of the reasons for an anomaly.
Okay, thank you. So whenever time is up, you're closing the station. How are you going to close this? Okay, so always say thank you for your time to the examiner, right? So I think somebody has please mute yourself. Anybody who's taking the consultation in OPD, please mute yourself so that others don't get disturbed, because this is also a recording which has been going on, so you can also listen to them. So Afshin, so now tell me, how did the station go?
Madam, not well. I made a lot of mistakes.
What mistakes you made? Anybody else would like to tell us that how she should have handled the station? Anybody else from the group? Yes, Sajida, can you please give us your points that what she had missed and how she should have done this station a little more better?
Madam, investigation should be focused, because if this is by coronary uterus, first the history should be exclude all the abnormalities of the uterus, that she has miscarriages because of a particular reason. So we have to exclude the other causes, and we have to go for focus history on that point. The other thing is that she said for investigation, we have to go for laparoscopy, hysteroscopy, MRI, this and this. So why all these investigation? Although can uterine anomaly, we go at least two modalities, but if ultrasound showed that the back-cornered uterus and these are the normals, and pregnancy can be stay in one uterus and it can continue. So I was just saying.
And one of the most important thing which you guys make, which I learned it through my whole course of, tenure of giving exams to different countries and different examiners. Whenever you're asking a question to the examiner, you're telling that this information I want, please justify it. Otherwise, there is no use of asking, do I have this information? Do I have? And tell the examiner, do I have this information? And I'm asking this information because this is coming into my mind. Okay? Am I making my point, Afshin? So, for example,
Yes,
regarding this patient, let's just come to the template. I've made it for you guys so that you should know that how you have to talk to the examiner. So regarding this, so what are the important points I asked you in the history and why? So just say that I would like to ask about, first of all, her age, if her age has been given to you, because bicornuate uterus is not at this moment is the only cause which is calling
yes.
responsible for doing this. Okay, so why only directed and only once in a one differential is coming into your mind?
Yes, this
right?
is what I want to say. Yes.
So just say that I would like to first ask about the patient regarding any complaint she's having at the moment. How is her, because she's been here with you with 3 miscarriages now. And now she's here to talk to you regarding how I can prevent this happening in the future. So the scenario is in front of you. You are going to ask the examiner that regarding the patient, she's having miscarriages. So I would like to first ask about if she's having any active complaint at the moment and how is her recovery after that. And has she needed any counselors yet, or any infections through which this procedure would have been occurred or would have needed any antibiotics? And now I would also like, as her age has been given to me, I would really like to go ahead to ask about the partner's age, because old age also increases the risk of miscarriage. So now you are just, guarding the examiner that why I'm interested in learning this information, because this is coming into my mind. So now the next question I would like to ask is about her previous substatic history, the age of miscarriage, what happened? Was there any rupture of membrane? Was it a live baby, or a baby died after delivery? Was it a sudden bleeding and baby miscarried with no pain or cervical? Because I'm trying to exclude out cervical weaknesses. Any alive baby at which gestation deliver any rupture of membrane before delivery to rule out for cervical causes. So now I'm saying, now this will be coming into my mind that this candidate is actually the candidate who deserves to be passed, because she's actually not directed and, one bicornuate uterus. So she's been having different types of, diagnosis she's been coming and she's ruling out those differentials. So I would give you at the end. Now, right now, I'm not giving you information because I want to listen all the differentials from your mouth. Now, I'm going to ask about her gynae history regarding her periods or any contraception used so far. The smear history is very important for me. And what kind of smear was that? Was that a normal one? She needed any treatment in the form of leads or cone biopsy? I am asking this question because this is going to clear in my mind that she's not having any cervical insufficiency and would might need to be taken care of with the progesterone or any cerclage in terms if this might need it to. Then, is there any history of any medical problems like diabetes or connective tissue diseases or history of clots or any chronic medication she's been using to exclude out for any chronic conditions that she has been suffering from? I would like to know about her allergies, because sometimes if you're going to give her heparin or loperin or any other medication. So these history points would be very important for managing her with, better management options. What if she has a allergy with heparin? So what are you going to talk to the examiner if the examiner says, yeah, she's, allergic? So now the whole treatment is going to be different from the examiner. With the examiner, you're going to discuss with her. So the alternatives you're going to talk to her about, right? So after that, fondaparinux or danaparanoid or something like that. So things like that. So this has to be. So now you're giving me this information gathering wise. I really want this information to be clued out. So now the examiner thinks in his mind that she is a deserving candidate.
जैसी
That
बेटी
she
की दफा
knows,
थी मुझे
please,
रिपोर्टें ला के दिखाओ बिस्मिल्लाह जब तक बेटा मेरे पास सारी रिपोर्ट्स नहीं ना
Dr. Lasanya, please mute yourself. Okay. So now the examiner would like to, he is very impressed that her mind is going towards this level of knowledge that she knows that she's ruling out even the allergies because she's has to plan for the management of this patient. Now you're asking about height and weight ratio of the patient, BMI. Why this is important? Because high BMI also leads towards miscarriages, right? Don't do the high miscarriages also cause this increased risk of miscarriages? Yes, they do. So you're also excluding this out. Any surgeries in her, abdomen or down below to rule out for any cervical manipulation or surgeries, and any family history of clots and social history like smoking, alcohol, recreational drugs. You never know that this history might be positive and you might have to change, the whole pattern of your management, just and you're not just giving the hysteroscopy or something bigger investigation. So in examination, you need to know about the palpable uterine masses in terms of subserosal fibroid or any short cervix or cervical incompetence. And in investigation, you need to have an ultrasound scan to rule out for anomalies or structural anomalies. So right here, the examiner is going to give you the investigation the way I have given you the ultrasound scan, that this patient is having bicornuate uterus. So now you are more targeted towards this, sometimes even after listening to the whole investigation, because examiner wants you to see that you're not actually targeting your mind towards only bicornuate uterus. So stay till now investigation. I might not give you the investigation findings till the time I hear you that what else you can, think in your mind. So you can say right now she's having second trimester miscarriages. Please mute your mics, guys, because it interrupts a lot while you're talking. Okay, please mute yourself. I'm very thankful to you guys. Thank you so much. So the ultrasound, and right now the examiner has still not given you the information of investigations like bicornuate uterus. So your mind is thinking about what else could be the cause of second trimester miscarriage. Now, blood test, antiphospholipid antibody syndrome I'd like to go for this patient. And what are the antiphospholipid antibody syndrome investigations I need to rule out this? Anticardiolipid antibody, beta-2 glycoprotein, IgG and IgM. And this has to be repeated after 12 weeks so that we can make a diagnosis confirm that she's having, or there may be a history of antiphospholipid antibody syndrome to be present. I need to exclude thrombophilia screening for this patient. I need to rule out any problems in the baby previously, because this is the fourth time she will be conceiving. So I would like to exclude any karyotyping done to the product of conception so that we can see that was there any kind of element of translocation which was present. And then if there is some problem with the one of the partner, we can, or the parent, so we can go for both partner chromosome checkup peripherally, because this might be 10 or I think 15% of the cases who would be presenting with us with such kind of scenario. So now the examiner give you, this is the investigations, or examiner still not, if the examiner still not give you the investigation finding, then you have to talk about generally touch all the things like antiphospholipid antibody syndrome, aspirin and low molecular weight heparin from the start of the pregnancy, thrombophilia, low molecular weight heparin from the second trimester, a chromosomal abnormality, genetic counseling, and PGDs, testing and IVF, and testing before embryo transfer to overcome the problem. If weak cervix, I'll just go for stitching epidural. Next pregnancy, we need to refer her to recurrent miscarriage clinic for follow-up. The risk is 1% for the couple, so need counseling after miscarriage. And there are 70% of chances of having successful pregnancy next time if no other cause is found. Now, if the examiner give you this, the way I've given you, so now I pose you few questions afterwards. What will be the answer of these questions? Let me just come towards it. What about the uterus? Okay, so prevalence of recurrent pregnancy loss, miscarriage is sporadic and also 1 to 3%. And so why it actually needs to be evaluated, because most of the pregnancies we've been having these kind of losses, and after, especially whenever the couple is going towards the third time of any miscarriage or has been here with us, we need to rule out and do a proper RPL, recurrent pregnancy loss workup. So what to do? Patients generally want to know what was the cause, what is the risk of happening again, and what can be done to evaluate and treat the problems if it's found. So you need to remember all these percentages, because this is going to help you out. Talk to the examiner that 50% of the cause is idiopathic, 5% genetic, anatomical is 20%, and 10% is endocrine, immunological, 10%, and infections, 5%. So the question, let me just first come towards the question I asked you. Yeah, so I asked you about, is it a congenital abnormality or not? You said no. Why you said no? Why you said no? This is I don't know why you said no. This is how we do it in front of examiner, right? We forget common things. So this is a congenital, congenital uterine abnormality. And then I ask you, can you classify this? Yes, this can be classified according to the ISSURE guideline, which has been given to us. And this shows about 6 classes. Class 0 shows normal uterus, class 1 dysmorphic uterus, it may be T-shaped or infantile, and class 2 septate, class 3 it may be diffuse septate, and class 4 unilaterally formed uterus, and class 5 aplastic, and class 6 unclassified. So this was my answer I wanted you to give me. So this is an easiest way to remember this: class 0, class 1 you see, and class 2, and class 3, and class 4, and class 5. So you can now well imagine that what kind of uteruses are there and how can it be classified. They can even ask you the image that I've given you, and they can tell you, they can even ask you that what class this bicornuate uterus come. Okay, so this is the only important thing which they can ask you from ISSURE guideline, and this question has been asked, right? So that's why I asked you this question. So this is the classification I've just told you guys. So my next question was that do you think is it necessary to investigate for uterine abnormalities in all cases, and what are the limitations? Yes, guys, we have to, whenever the patient is coming with recurrent miscarriages, has been diagnosed, so you have to now investigate it so that you can know that is there any abnormality which may be causing this problem to occur. For example, this arcuate uterus. So this causes usually the second trimester miscarriages, and septate uterus, if it comes, it gives us the first trimester. So you can talk to the examiner like this. Yes, we have to investigate it if the patient has been diagnosed with recurrent miscarriages and it hasn't been excluded. 1.8 to 37.6% of the cases, as evidence from the Green Top guideline shows that if there is a structural abnormality, for example, arcuate uteri, it can cause second trimester miscarriage, or septate uteri, it can cause first trimester miscarriage. So if you give this kind of answer, do you think examiner is going to fail you? No. And why I am giving you this? Because I'm just not telling you anything extra. I'm just telling you only the knowledge from guidelines. Just memorize the guideline. And this is going to help you out, talk to the patient and talk to the examiner, right? So these are the questions which I have extracted from the guideline, because this is how I have been asked on this station in MRCUG examination. And this is how I have been asked in the station when I appeared for my MRCPI examination in Ireland. So both of the examiners are more, exams are more like same. And when I came for my FCPS examination, it was like, halwa. It was so easy for me because these questions was a similar one which I have been asked there. So these are the questions which are usually asked in recurrent miscarriages, station. So the next question was, and then I asked you that what investigate and how are you going to investigate it? So yes, you said rightly that all the women who has been with the first trimester miscarriages and all women, one or more second trimester miscarriages, they need to have a pelvic ultrasound to assess for uterine anatomy. And for the women who get the suspected uterine anomalies, they may require further investigations, so that using the hysteroscope, laparoscope, or three-dimensional pelvic ultrasound. But if it is not available, then we can make use of investigations like two-dimensional ultrasound scanning or hysterosalpingography with salpingo Sono hysterography, and MRI is the gold standard, but not the first one. So if you have given this answer, and this is all from the guideline, your Green Talk guideline, I'm not telling you extra, or I'm not telling you anything from the, something which I've gathered the information from any research. It's just the lines which I memorized from the guideline. And this is how the examiner is going to ask you. And this is how you're going to answer it. Okay. So be master of those guidelines, have it in your tapes. And this is the, the next question I ask you, what are the limitations with 2D ultrasound and HST? We use this as a first line to diagnose it. So you can just tell the examiner. So the limitation is that in 2D, we're still not able to see that how the septum is going to be inferred on. So this is a reason, and HSG, we were not going to have a three-dimensional view. Still, we're going to go for laparoscope and hysteroscope to see what other way uterus has been affected and causing the problems. And then the next question was that what's the role of Sono hysteroscopy and MRI? So this was, I asked you because you didn't give me the answer the way I wanted you to give me. So the next question I ask you, what are the available evidences? So this is the evidence which you're seeing in front of the screen. All women with recurrent pregnancy loss. This is from Assure guideline, guys. Just read it, the important points, make your notes, because this is the whole, important thing which the examiner could ask you on the uterine problems. Okay. So all women with RPL should have an assessment of the uterine anatomy. The preferred technique to evaluate is TVS, 3D ultrasound, which has a high sensitivity and specificity and can distinguish between septate and bicornuate with normal cervix. Sono hystero is more accurate than HSG in diagnosing uterine malformations. It can be used to evaluate uterine morphology when used 3D ultrasound, or when 3D ultrasound is not available, or when tubal patency has to be investigated. In Müllerian uterine malformation, if it is diagnosed, then further investigations, including investigations of the kidney and urinary tract, has to be considered. Remember, your Müllerian agenesis MRI is very important, because these Müllerian agenesis, 40% chances of having double ureter or kidneys. Remember this? Okay. So MRI is not recommended as a first-line option for assessment of any uterine malformation, but can be used where 3D ultrasound is not available. Now, my next question, number 5, was what are the evidences and which investigation are you going to offer to diagnose acquired uterine malformation? So it's just a continuation of it. So whether hysteroscopic septum dissection has a beneficial effect, improving the live birth rates and decreasing miscarriage rates, should be evaluated in the context of surgical trials. Metoplasty is not recommended. You can use hysteroscope and do the septum resection. If greater than 3 centimeters of fibroid, you can remove and improve the chances, but below 3 centimeters, still it is not, evidence-based that this is going to improve the chance of pregnancy, right? So this is how, with the context of your research, you can talk to the examiner. So this is how the things are. So uterine reconstruction is not recommended for hemiuteri and RPL. So this is from guideline. So you can say in the guideline, it's been mentioned that uterine reconstruction is not going to be make any difference, and there is insufficient evidence in favor of metroplasty in women with bicornuate uteri. Okay, so this is the question I wanted you to answer in this way. So all women with RPL should have an assessment of the uterine anatomy, and there is insufficient evidence supporting hysteroscopic removal of submucosal fibroid or polyp in women with RPL. Surgical removal of intramural fibroid is not recommended, and there is insufficient evidence to recommend removing fibroid. So if the examiner says, okay, so you say there's no evidence, and your patient is coming with second trimester and repeated miscarriages, and there is a polyp, why are you not giving her treatment? So what would your answer be? Afshin, what will you answer? Sajida, what would you answer?
Yes, ma'am.
Anybody else? So examiner says, if you're saying this is not recommended, this is not recommended, this is not recommended, your patient is coming with RPL. Now, are you going to remove are you going to give the, remove this endometrial polyp or any
Yes, ma'am.
fibroid?
I'll do. Polyp, if the polyp is present or as intramural fibroid is present, then I mean, usually I see that we first go for these type of surgeries and then, but
Okay.
I'm reading that
So
it is not recommended.
you said the answer, but you didn't say the way we have to give back to the examiner. So you should have said that, yes, though the guidelines and different evidence studies suggest that there is insufficient evidence that supports hysteroscopic removal or of any polyp or any fibroid, since my patient is symptomatic and these things has been making my patient symptomatic and no other cause has been found, so this can make a clear difference if we remove this polyp or septum hysteroscopically. So this is how you're going
Yes,
to answer,
okay,
right?
okay.
Okay. So
Words
this
matter
will,
a lot.
yeah. So how you have to tackle the station, how you have to start the station, how you have to always avoid madam, okay, during the exam. Okay. So be professional
Okay.
and introduce yourself that I'm Dr. Shafsheen. I'm one of the exam candidate. I've read the instructions. Now I'm ready to start my Viva. So just then examiner, then if she has or has any questions, is going to pose you for that. And then you have to just summarize it and never, find for your words and then answer. And this comes with practice. Okay.
Fine, ma'am.
Okay, so this was regarding the recurrent scan. Now I think you guys would have an idea that how the exam would be conducted and how you will be evaluated by short cases, like splitting up long cases and the role players. Okay. Do anybody have any questions?
Ma'am, in structured Viva, like with the examiner, we have to ask all the history questions to the examiner and examiner provide us the answers, na? Simply.
Yeah. So the way I told you that you're going
Yes,
to
ma'am.
ask the questions, give the reason why you're asking, and at the end, when you ask all the questions, then examiner will give you. It's not that please
Ma'am,
give me this information, give me this information.
after each question, we have to justify that why we are asking this question, and after each investigation, we have to justify.
Yeah. Now I think I've made my point clear, and now I'm successful. Okay.
Thank you.
Okay. Any other person who would like to ask the question?
Ma'am, other thing is that the examiner can ask any question in this station because in the last with the role player, on that patient was asking question to me, but the examiner can ask anything to us, no?
Yeah. So regarding this, no. It's not like long case that examiner can ask you. Yeah, the bad examiners, you never know that any examiner can. The examiner would be provided with this question. Let me just show you the question. Okay. Examiner will be given this question.
And we have to learn, madam, these type of classifications and every guideline or material, theory material as well.
Yeah. So this question would be given to you. An examiner would be given a key already. And in that key, there will be questions written. So the way I asked Afshin, 5 questions. Okay. So now I got to know that she is actually not clear in her mind and she is only targeted to bicornuate uterus management. The examiner can divert her questions to assess her that whether she knows recurrent pregnancy station or not. Okay. So this is a subjective type of assessment that comes in objective type of assessment.
But madam, these are the structured thing, na? So examiners are provided keys. So how can they divert us to something else? Matlab, if we are expecting something, they have to pull
for
us
example,
on the way.
Very easy. For example, if Afshin is not answering my any of the questions the way she was not answering, examiner can go back to the previous things because the examiner has now got a clue that she doesn't know the management of uterine abnormalities. Now she has given not enough information of even she didn't ask me about anything from the investigations or anything from the questionnaire or history. So she would like to ask because she wants you to give you questions, ask you questions. She wants to give you marks. She will say anything else you would like to ask. Anything else you would like to ask? She might direct you that please ask this question. Won't you ask this question? Won't you ask this question? She might bring you to the station that you're missing these points. And if she is unable to come up with those questions, then examiner is going to have an idea that she doesn't know the station. So she will mark you 0. So still this is in the hands of the examiner But it becomes a little bit objective because there has been 5 questions that has been given to us.
Okay.
Anybody
Fine.
else would like to ask any question? So you need to remember that whenever you are discussing a station of recurrent miscarriage, since we've been given the example of this recurrent miscarriage station, so always talk in line of these headings: genetics, hematology, immunology or rheumatology, maternal fetal medicine, because there may be some congenital problems that may be present to the baby, to the fetus. Gynae, that is like any uterine septum or congenital problems. Any fertility unexplained fertility problems would also be going on. Psychiatric issues, pathology, and urology, meaning men's health, that is semen problem with the men's also. So genetics, yeah. Anybody else? Do somebody else have a question?
Ma'am, if the patient is with the bicornuate uterus and now she is pregnant, how will we counsel this patient that what problems will with you?
So regarding this, now if it has been diagnosed, then we can tell the patient regarding कि उसकी बच्चेदानी के साथ ये मसला है और उसके pregnancy जो है उसमें miscarriage के chances बहुत ज़्यादा है. And in that case, we can, if she's pregnant, then we cannot do anything. Just only the monitoring of the patient we are going to take forward along. And early preterm deliveries can happen. And she might not end up with any of the problem. There are no studies which shows that bicornuate uterus cannot have any successful pregnancies. So they can have a very good pregnancies, but these problems remain there: miscarriage, and preterm delivery and cesarean sections, and baby problems also. Because if this is congenital, there are chances that the baby might have this problem inverse. So we might have to do screenings, and this care has to be multidisciplinary. Now, after delivery, she can have a normal delivery or might have a cesarean section because second convert can hinder in the process. And after the delivery, the baby, so she is going to be discussed about the management or the surgical options, which will be in the collaboration of multidisciplinary team here. Okay, so this is how you handle the station. So usually they do.
Ma'am, I want to ask one question: that should we have to ask about parental karyotyping?
Yes, at this stage when the examiner has not given you any investigation of bicornuate uterus. Okay.
Okay.
Before
and
that,
should we ask about cervical length? Because in uterine anomalies, there are chances of cervical incompetencies, no?
Yeah. So you will say that. And also one more thing you will say, even if the findings has been given to you, even if the scan has been given to you, still you're going to discuss about the karyotyping, because she might be having the translocation that would have been going on, and now accidentally she has been diagnosed with this bicornuate uterus also. So you need to talk about, holistically. You have to make your approach broader. Okay.
Okay.
Anybody else? Anybody else? If there are any questions, invited. These questions are invited.
One thing I want to ask, as you told that there could be male problems too. The thing is that if the patient, the male is having esospermia, obstructive or non-obstructive, then we go for either we're going to say to the examiner that we're going to refer to the urologist, or we are going to tell the examiner that we are going to refer him to the specialized center for the testicular biopsy, and later for the ICSI and IVF.
Yeah, but in that case, the patient won't be able to conceive. Na? So if the recurrent miscarriage occurs, and if the examiner gives you such questions like there may be a problem with the male factor, so what would you do? Then in that case, you can say that there might be different problems. Don't divert the examiner towards yourself, unless the examiner says, because it's not the demand of the station at this moment. तो उसमें क्या होगा, आप अपने आप को फंसा लोगे और एग्जामिनर उधर चला जाएगा और ओके तो मतलब you were thinking this, why you were thinking this, and then you will direct the viva towards our fertility and would forget about the station, and time would up and you won't be able to complete the station. So this is how the examiner can become subjective from objective question. Now coming to your question, so the question was the patient's husband is having esospermia, and what was your question, Fatma? So the patient is having esospermia,
And actually, I want to ask that in case of obstructive esospermia, of course, we have a cause that there may be epididymal blockage, and we can retrieve the sperms by doing testicular biopsy. But what about non-obstructive esospermia?
Yeah, so in that case, still you will answer that the way you have answered me before, because still there are chances that you can retrieve the sperm, and this is not you are going to decide it. This is something the other specialties are going to decide. So we will be referring to the patient to the andrologist or urologist for having a detailed checkup, examination, and then testicular ultrasound, and then they can do the testicular biopsy. If they found out any sperm in it, then they can use it for IVF fixie after doing karyotyping. Why is that male person having azoospermia? Maybe that person is having karyotype, needs to be done karyotyping, because most of these patients are having any congenital problems which usually comes up with them. And even if we're not doing the karyotyping and we're taking the sperm by testicular biopsy and that sperm is defective, and the pregnancy, now we are giving the IVF and the embryonic pregnancy comes out because there was genetic defects. So this is how you talk to the examiner like that. But I would really encourage you guys not to go so deep, because this is going to dig a hole for you in front of the examiner. Be very basic towards the examiner. Okay, whenever, if the examiner wants to ask you in sub-fertility station, yeah, give the answer. In recurrent miscarriage, don't brag this up here, because this is going to be a very big hole, digging a hole. Okay, anybody else?
Madam, I just want to ask, focus means if we are, in this case, if you want to ask about family history, so we have to just ask about the family history of uterine anomalies and like diabetes, hypertension, just like that. Now, we don't have to go through
And
like
you just have to say that I'm asking this question. I need to ask family history of concern of diabetes, any thyroid condition, in order to see whether these miscarriages has been caused by any chronic illnesses or SLE. Okay, so you're also justifying why you want this from family history.
Okay.
So this was the important things which I wanted you to know about recurrent miscarriage, and wanted to give you an idea how this can be done. So PGT genetic implantation, you need to discuss it. If the examiner tells you that there is some problem with anomalies, you just say that we can go for as 70% of the chances of having successful pregnancy next time she conceives. So we can go for the spontaneous pregnancy, though there is an option of pre-implantation genetic screening test, which can be done to the patient, but the pregnancy rate with using this technique is only 30%. Okay, so this is how you're going to answer this. If there is a viva, which usually get toward the, so uterine causes we have discussed, and let me just tell you more. So blood clotting. So if the recurrent miscarriage station goes towards any problem with the blood clots, so what's the role of hematologist? Hematologist, you have to bring the hematologist here. History of bleeding, history of blood clots, family history of blood clots, and any disorders which has to be looked up for the hematologist. You have to rule out antiphospholipid antibody syndrome. Why? Because there has to be clinical criteria and laboratory criteria. We need to talk to the examiner so that we can also not rule out for anything to be missed, and she can be put on low molecular weight heparin. So testing for inherited thrombophilia is usually not routinely performed, but may be obtained based on family history. And low molecular weight heparin is indicated for antiphospholipid antibody syndrome and personal histories of thrombosis. And dogs has not to be, this not approved in pregnancy, and then the examiner can even take up the viva towards epidural. So this is how the examiner is going to be subjective from objective paper. Okay. So these were the important points I wanted you to know about. Anybody else would like to ask a question? I'm open to the questions right at this moment.
Ma'am, you have told about the heparin allergy. If patient is allergic to heparin, then what do you alternate?
In that case, we have other options. What options are there? Please tell me. Danaperonoids, fondaparinux. These are the drugs which you can use alternative, and these are safe to be used in pregnancy. Okay. Otherwise, if she's not pregnant, then we have got direct oral acting, anticoagulants. These are also available, right? Okay, guys. Anybody else would like to have question for this was the question. This was how I wanted to give you the idea regarding FCPS extended OSCE changed pattern, which is somehow now become closer to the international pattern. And this is also a very technical exam to deal with. If you do not know how to deal with it, you can even fail the stations. If 6 stations go borderline and 7 stations go passing, still you are passing on borderline. If all the stations go above borderline, by knowing about your domains, you can easily pass this exam easily in your first attempt. But you need to know how you have to deal each station. So by this exam, they are going to see all the different modules. First, they were doing it with the long case, only 2 cases. One was getting rare cases, one was getting, most common cases. Now everybody is going through all types of modules. Now you're going to be discussed in that same exam. Cervical cancer, you're going to come across in the same exam the station of SLE, the station of diabetes. Everybody is going to talk about labor ward, and everybody is going to be talk about laparoscopic instruments. So everybody is going to be talked about abdominal hysterectomy, right? So, but this is more like studying like a written exam. If you know, study this exam OSCE pattern in a written, the way you have done it in your written, but extra efforts of practicing and talking in Urdu and also talking to the examiner, memorizing your guidelines and your tips, then you will go through this exam easily. Or if you need my help, so this course has been arranged by a med exam expert. Thank you for being here with us. And if you want to book this course, the details will be given to you by med exam expert team. Thank you so much, guys.
Thank you, Dr. Asma. Thank you. It was
Please
nice
give me
clarifying.
feedback. Please give me feedback in the, to the med exam expert team so that they will know that how did this session go. Thank you so much, guys.
Thank you so much, Dr. Asma.
Well,